I'm very excited to have these speakers with us today to talk about the impact of COVID on refugees and internally displaced people in the Global South. As you know, Global Washington is a network of 165 organizations that have a presence in Washington state and work to improve lives in developing countries. And since the pandemic started, Global Washington has really shifted our focus to support our members and what they're doing specifically in relation to COVID-19. And we have an amazing network that really is responding in multiple ways. We recognize that this is a health crisis, but it has multiple impacts beyond just health. As you've started to hear, and as many of us are experiencing here in the United States, the economic impacts and the security impacts and other issues that impact people's daily lives is really something that Global Washington is looking at because we have this diverse network of organizations. So we look at the intersections and look at the comprehensive approaches to some of these problems. So thank you all for joining. This is, I think, number 14 in a series that we've been doing since March. And we have another one, the next one coming up. We're taking a little bit of a break next week and possibly the following week. But in early June, we're going to be coordinating with the Final Mile group that's run by Eric Klunder. And we'll be looking at lessons learned from the Ebola crisis and what we can apply to COVID-19. And we actually have the person who headed up Vulcan's response to Ebola years ago, and now he's at the Center for Disaster Philanthropy. So Brennan Banks will be joining us, and Ann Peterson, who's the Vice President of Global Programs at AmeriCares. So we'll get that date confirmed today and get that out to you for our next public event. So today, again, if you're just joining us, welcome. Please go into the chat box on the bottom and type in your name and affiliation and make sure you're sending to the panelists and all attendees. One of the things Global Washington wants to do is to create more community around this. We know that many of you are still isolated at home or staying at home, and Global Washington wants to create the community of those that care about global development. So we encourage you to reach out to others that are on this call and make sure you're known there. The way we're going to be doing the program today is each of the speakers will present for about 8 to 10 minutes, and then we'll go into Q&A. And the way we're going to do that is that there's a button at the bottom of your screen under Q&A. We'd like you to type in your question there, and then I will verbally ask the question to one of the panelists, and they'll verbally give an answer. We'll hopefully get through all the questions, but if not, we'll try to collect all the questions and get back to you after it. And after that, and please don't type in your questions until around 10:35, because the panelists might answer your question during their presentation. But I'll type into the chat when it's time to start thinking of your questions. So I'm going to introduce the speakers briefly, and then we'll get the program started. First, we have Erica Van Duren, who's a Senior Program Manager for Humanitarian and Emergency Affairs for the International Programs Group at World Vision. She's been at World Vision for almost 10 years, and she's been overseeing the disaster management of complex humanitarian crises all over the world. She leads the coordination right now for the World Vision US Global Emergency Response to COVID-19. So we're very happy to have Erica here with us today. She's based in the Seattle area, and so we're lucky to have her here in our community as well. Next, we have Etan, who's the Manager of Child Migration and Protection Programs at UNICEF USA. He's usually based in New York City, but right now he's in Southern California with his family there. He's been at UNICEF for nearly 3 years, and he works with the whole Latin American team, but specifically he looks at migration flows in Central America. He's also worked on several anti-trafficking efforts throughout the world as well. Next, we have Betsy Baldwin, who's the Director of Humanitarian Response for Medical Teams International. She's been at Medical Teams International for the past 2 years, but prior to that, she's also been at Tear Fund, which is actually another Global Washington member, so it's glad to see that. And at Tear Fund, she worked all over the world, but specifically in Iraq, South Sudan, and Afghanistan. Previous jobs also include working with the Salvation Army World Service Office and at World Vision. So lots of good Northwest connections for Betsy as well, but she is now based in Washington, D.C. So we're going to get started. And again, each speaker is going to speak for about 10 minutes, and then we'll go into Q&A. Betsy, I'd like to start with you. If you could kick us off with more of an overview of the topic and what your organization is doing.
Thanks so much, Kristen, and great that Global Washington is convening this conversation. I hope it's helpful to people as we think about the impact of COVID-19 on refugees, displaced, and those generally affected by humanitarian crises. So just briefly to give a global overview, I'm sure you hear lots of numbers every day, but globally we are approaching about 4.5 million cases of the virus. But in many of the world's most acute humanitarian crises, we've actually not seen widespread transmission of the virus just yet. I say that very hesitantly, which I'll get to in a second. Overall, the UN has estimated that the cost of this response for COVID-19 will be $6 billion. They had originally issued in the Global Humanitarian Response Plan for COVID-19 a $2 billion request, and then updated it last week and over tripled the value of the need. That reflects the need for everything from more food assistance to adapted education programs for displaced children, to treatment and isolation wards for refugees, to improving logistics networks for humanitarians to get in and out of crises and deliver essential supplies that need to be used to save lives. The reason I hesitate to say it's really not been that bad just yet is this week has been concerning. We've seen that perhaps we are on the brink of a large spread of the virus. We've seen things like testing increasing in South Sudan. It's largely been 100% absent, despite rumors and confirmations of a case here or there in countries bordering South Sudan. We've had 3 cases confirmed in what many people refer to as the largest refugee camp in the world, known as Kutupalong refugee camp in southern Bangladesh, where you have the Rohingya refugees from Myanmar. And I believe Erica will speak more to that. We also just have fears around the picture of the outbreak in places like Tanzania not being known, and seeing fear and infection spread over the border into some of our programming in Uganda. And it's the fear around the virus is affecting our ability to just deliver essential health programs like we do every day, around things like prevention of measles. The work of medical teams works across the continuum of care, from community or public health and all the way to partnering with Ministry of Health and strengthening health systems or delivering direct health care ourselves. One of the most important aspects of the COVID response, and any response, really is trust with the communities. How do we build their trust and retain their trust with good information and encouraging good practices and learning from what has helped in mitigation of transmission in places like China or South Korea, and how can we adapt those to the challenges of the settlements that we work in places as diverse as settlements in Africa to Bangladesh, and then to the various migration crises in South America. And then just keeping in mind that what we may be able to do here is not as applicable to places where people live, where they share communal sanitation and have to touch the same water pump, or where they were only relying on informal labor opportunities and the economy of their country that's hosting them is entirely shut down and there is no more informal labor to speak of. As well as living in very small places, maybe only having a 12 by 12 small tent or a house in somewhere like the Bekaa Valley of Lebanon, which hosts around 300,000 Syrian refugees. how can we encourage those people to understand the virus and for them to identify the solutions? But how can we also not frighten them when we've been standing up isolation and treatment units that have been perceived as a fearful thing by communities and cause them to attack it, thinking that even with a clinic located in their neighborhood, perhaps the virus would come to them. And just communicating clearly and just through adapted means to not put people at risk by even speaking to people too closely, but thinking, how can we use WhatsApp and radio and other means to build their trust, and also to build on experience from previous disease outbreaks, like anything from yellow fever in Uganda to Ebola in West Africa. I just want to highlight one particular crisis before I conclude, and that's the situation of the 5 million Venezuelans that have been displaced into neighboring countries. Many of you are familiar with Venezuela has struggled to provide basic services to their citizens for a number of years as their economy is in decline. That includes a very broken health system, and many people have fled for those reasons and many others. Colombia hosts nearly 2 million of those migrants, and Venezuelans in Colombia only have access to one part of the Colombian healthcare system, and that's emergency care. And even accessing a service in the ER is exceptionally difficult. We have spoken to many people who you need to be in active child labor, or you need to potentially be unconscious or demonstrating a very severe illness to get into an ER. Sometimes they even may have to bribe officials to get into the ER and receive care, and then often don't receive follow-up care. Their situation, like I mentioned, is the Colombian healthcare system is overburdened from Venezuelans, but then this COVID-19 situation will further exacerbate it. And then really we have to be creative as the humanitarian community to think, how else can we shore up that Colombian healthcare system, but then also support Venezuelans to, as they're living in very basic settlements, again, similar problems, small houses, or I'm aware of many settlements don't even have piped water, and essentially people just have to buy their own bottled water or get their neighbors together and bring a truck of water into their communities. How can we support them to limit that transmission? But also just thinking of all of the gains that have been lost with things like lockdown, and how do we recover from those? What sort of, we talk about erosive coping mechanisms of, cutting down their meal sizes so their food budget is less, so that they could maybe pay for some prescriptions for a sick family member. What else, how else will this virus impact some of those acute populations in need? I'll leave it there for now, but look forward to the other panelists' input and your questions. Thanks.
Thank you, Betsy. That was a great global view of what's going on. Erica, I wonder if you could dive in deep to in a few countries and tell us a bit more about those situations and what World Vision is doing there.
Yeah, absolutely. Maybe just a quick introduction to World Vision. We're a large child-focused relief and development agency. We do a large number of disaster response, emergency response activities. And the COVID-19 response is the largest humanitarian response we've ever had. It includes over 70 countries where World Vision works globally, but we're particularly concerned around fragile and conflict-affected countries, and really making sure that even as we're thinking about the Zambias and other countries, that we really are keeping a clear focus on where this is going to be the worst, especially in these refugee camps. And our response is focusing not just on, as others have talked about, not just on the health impacts of the pandemic, but also on these secondary impacts, which don't feel very secondary when it's an impact you're having in your family, whether that's livelihoods or child protection or education or food security. It's just going to be really broad across a number of issues that these communities face. And so refugee communities are vulnerable, not just because of the pandemic, but also the secondary impacts, a reduction in the regular humanitarian assistance that they may be relying on. And so I thought today I could talk about to refugee or IDP settings where World Vision works, the Rohingya camps in Bangladesh that Betsy mentioned, and then also talk a little bit about our work in Afghanistan. The experiences of the populations in these areas really are like a microcosm of what the virus's reach is going to look like in the most precarious parts of the world where we work, where we see just multiple vulnerabilities from climate change and conflict and violence and territorial disputes. And I want to sort of draw out some of those themes a bit, and then hopefully also talk about solutions. Sometimes these speaking engagements can be quite depressing and you leave feeling like, well, this is useless. But I do think there are some things that we can be doing. And one of the unique things about this crisis is that we, in some ways, can see what's coming and try to be prepared for that. So, for example, let's talk a little bit about Bangladesh. So, as Betsy mentioned, it's the largest and most densely populated refugee settlement in the world on the Myanmar-Bangladesh border, home to Rohingya refugees who fled ethnic cleansing or genocide in Myanmar. And as Betsy mentioned, just yesterday, the first cases inside the camps were confirmed. And one of the things talking to our team there last night is that the last 5 or 6 weeks of people fearing this virus coming and it not having come yet was a great opportunity for us to do what Betsy was talking about, building trust with the refugee community, with the host government, with the host community, that we know how to deliver life-saving humanitarian aid in a way that is safe and can prevent the spread. So I think at the beginning we were worried this virus is going to come and the government's just going to lock the camps down and say best of luck to the refugees. And now that we've had 5 or 6 weeks, people were a little less concerned that we're going to see this huge overreaction, and we're going to, not overreaction, but it's a really restrictive environment for those refugees that we think even as the pandemic is moving through the camps, we'll be able to maintain critical life-saving humanitarian aid that these people rely on. So that early action is really indispensable across all settings, but especially refugee settings. One of the other things we're seeing in the Rohingya camps is really large increases in gender-based violence and child protection needs, which is something that was in the camps before the crisis, but the nature of lockdowns and being trapped at home and just higher levels of stress, less access to referral mechanisms. Women may not be able to get out into the communities and be talking with other women, and it just increases the vulnerability there. So one of the things we've been trying to focus on with the government there is when you're defining what is truly critical life-saving work that's allowed to keep happening in these camps, protection and gender-based violence has to be considered one of those life-saving things. It's not just food aid or water, but that protection is life-threatening, and that's something we need to keep an eye on. One of the other challenges in the camps is access to information. So since September, the government has shut down internet access and really limited phone usage inside the camps. And so if we're seeing that there's less access for humanitarian actors getting into the camps in person, and we can't send text messages in and we can't use the internet to access information, it just creates this infodemic, the new word of this crisis, where there's a lot of misinformation around what's happening with the disease. One of the rumors that we've heard going through the camps is that some people think it's 100% fatal, which, could you imagine seeing this thing coming and thinking anybody who gets it is going to die? Just the level of fear and distrust, and you wouldn't want anybody coming into your refugee camps if that's what you've thought. Also, in the past few weeks, we've heard rumors in the community that only women and girls are vulnerable to it, and that good Muslim men and boys are not vulnerable. So that means that men and boys may be putting themselves more at risk, and it also means that women and girls are more trapped at home, which increases that child protection and gender-based violence concerns that we're seeing. So using things like we're driving through the camps with megaphones to give good information, the critical life-saving aid that we are able to give, like food aid when people are waiting at a safe distance for their World Food Program food, providing correct information about the virus is something that we're doing there. And then the other thing I would mention is partnering with trusted leaders. World Vision does a lot of work working with local religious leaders, and I can talk a little bit about that in Afghanistan also, but in many cases, the messenger is as important as the message, and that's one of the big things we learned in the Ebola outbreak and continues to be true in these refugee settings. If you have a limited number of messages that people can get because of the restrictions, ensuring that who they're hearing it from is someone known and trusted, like a faith leader, can make a really big difference. And then just the one other thing I want to mention that we've been thinking a lot about, I don't think we have a solution to yet, but as we see these restrictions around COVID-19, one of our concerns in the Rohingya camps is that restrictions on free movement wouldn't be discriminatory and that they would be proportionate and they're not used as a political way to further control or limit the human rights of refugees and displaced people, but that they are proportionately spread across. Just really quickly, Afghanistan, where World Vision works in Afghanistan is in the north, I always have to think east and west, in the northwest part of the country on the Iranian border. And for a long time, Afghans have been going into Iran to get jobs and send money back to Afghanistan, or as sort of a first starting point as they're migrating out. From January 1st to April 11th, as this pandemic started up really, really big in Iran, almost 250,000 people have crossed from Iran back into Afghanistan. At one of the crossings in Herat, where World Vision works, there was more than 15,000 people in a day, and normally that crossing has about 300 people, and almost all of them are going in the opposite direction. So as people were fleeing the pandemic, they were bringing it with them back into Afghanistan. And so Herat was the center of the first outbreak in Afghanistan, and then it's since sort of spread across the country. And then along with returnees, there are a huge number, I think Afghanistan has one of the highest numbers of internally displaced people just from conflict and drought and all of these other vulnerabilities in Afghanistan. And they have an incredibly underdeveloped health system. I think it's less than a third of people are within a 2-hour walking distance from even a very rudimentary health facility. So in terms of vulnerabilities and testing, Afghanistan is really just incredibly a case study of how challenging working with this pandemic is going to be and how intense the secondary impacts are going to be. I was talking with a staff person in Afghanistan and asking him how it was going. He said, we've been through wars, and even in wars, especially in this part of Afghanistan near the Iranian border, the economy has functioned. We've been doing trade in and out of Iran, things have been moving. And he said, this is the first time I've really felt like the economy is shut down because of the pandemic. And so how much more vulnerable are these people going to be? Misinformation has been a really huge issue within the IDP camps. We've also heard the rumor in Afghanistan that if you die or have COVID-19, that the government will take your body and burn it and won't release it to your families, which is a truly despicable thing in general, but especially for very observant Muslims. So after that rumor started, we saw people like breaking windows in hospitals and trying to escape, and just thinking about how do you control infection when that rumor is happening. So again, working closely with faith leaders to reach people. And then World Vision has mobile health teams that we've been working with through the IDP settlements, and really wanting to ensure that those continue and they're part of COVID-19 protection and prevention, but also that providing for the basic health needs that pre-existed the pandemic are able to continue there. I think thinking through those secondary crises and the secondary impacts in some of these complex refugee settings helps us plan ahead a little bit and think about what should the global community be planning for and doing as we're thinking about this pandemic. Thanks.
Thank you, Erica. That was good information. It's always important for us to understand what it looks like really at a local level. So thank you. Etan, can you tell us a little bit more about your work and Central America in particular, and migrants coming to the United States and the work that UNICEF is doing there?
Absolutely. Thank you for having me, and thank you to both Erica and Betsy for that great kind of global overview, and for Erica for taking us to different parts of the world. It's amazing how similar so many of the responses are geographically and the approaches. So as she mentioned, my name's Etan. I've been at UNICEF USA for almost 3 years now. UNICEF, for those who are unfamiliar, the United Nations Children's Fund. We work in over 190 countries and territories around the world through a number of interventions. And I'm going to talk today specifically about our child protection interventions in the Central America, Mexico, US sort of sub-region migration corridor. So this has been a very active corridor when it comes to migration for a number of decades now. And our programming is generally embedded into our general child protection work. So the vantage point being a child is a child regardless of their nationality, where they're from, where they're going. And so they should have access to the same systems, et cetera, wherever they are. So 2 things that I want to focus on that are part of our sub-regional response. Kind of the 3 main pillars of our response are safety at scale, so preventing the violence that is forcing people to flee, creating communities of care for folks as they flee, and then trying to facilitate a return to normalcy wherever they get to, whether they're deported or if they're successful in their claims for asylum to get refugee status, et cetera. So I'm going to focus first on communities of care, and then I'm going to talk about the return to normalcy. So when I say communities of care, in essence, what we mean is, practically speaking, is we don't want children in immigration detention. About 100 countries in the world use child immigration detention, where essentially a child crosses an international border seeking protection, and the first thing that a nation does is incarcerate them. And this is something that is expensive. It's bad for a child's short-term and long-term development, regardless of a pandemic. And it's acutely problematic when you have something like COVID that spreads so quickly because of the inability to practice things like social distancing in immigration detention facilities. And so for example, in Mexico, we have worked, our UNICEF Mexico colleagues have worked closely with the Mexican government to try and advocate policy-wise to end child immigration detention, to get them to commit to not institutionalizing kids in that capacity. And there was that commitment in 2014. They passed a law that essentially committed them to doing that. But as is the case in a lot of middle-income countries, the policies and the practices have a gap that international organizations tend to help facilitate and local NGOs. And so in trying to build that, one of our efforts is to scale up what are called open door shelter models and foster care models. And so an open door shelter, as opposed to a closed door shelter, which is like a detention facility, a child will have access to some mental health and psychosocial support, though they may get access to some legal support. They're protected in the space that they are, but they're free to come and go. They may leave to go to school and come back to the facilities. And the second piece, foster-based care, relatively straightforward, placing children with families that are willing to care for them temporarily rather than placing them in detention facilities. Now, these are both relatively new interventions in Mexico. 2014 was when the law was passed, but it's taken a number of years to actually get those pilots. The way that COVID-19 has really interrupted that is that the Mexican government is now hesitant to place people in these facilities, to open the facilities that were meant to open. So the way that that's had to shift is we've essentially just had to move everything remote. So whereas previously the trainings for child protection authorities or for the NGO shelters that would be overseeing these kids would have been in person, we've had to move those to be more virtual. And the second piece that I want to focus on is the return to normalcy. So that was the first, communities of care. And the two are related in a sense. So when you have something like detention that is not caring, not by the community for a child, or when you have harmful border policies like the US's decision to effectively stop asylum processing at the border, that creates the need for a return to normalcy. And generally what that means is some sort of mental health and psychosocial support, which again, we've just had to move remotely. But one thing that has complicated that especially, and that I want to focus on for the remainder of my time, is forced returns. So whether it's from Mexico back to Central America or from the United States back to Central America, what is essentially happening is the children are arriving either in Mexico or in the United States. They're being detained and placed in a more vulnerable position where they're even more susceptible to contract COVID-19. They're not properly screened medically or tested for whether or not they have the virus, and then they are returned to places like Honduras, El Salvador, Guatemala, whose health systems do not have the capacity to deal with an outbreak. And effectively, those countries have been closed to international travel, with the exception of deportations from the US and Mexico. And so while we're continuing advocacy to try to get those forced returns to stop, and we understand that countries want to take precautions to stop the spread, but we don't think that the solution is to close borders. We think the solution is to continue with asylum processing and just to institute better screening measures and better health measures as you go along doing so. Now, as Erica was mentioned, there is a lot of misinformation about the spread of COVID-19, particularly in rural and indigenous communities, but all over the world. Central America is no exception to that. And what we're seeing happen now with these forced returns is an increase in xenophobia to these returnees when they're coming back to the communities that were already unsafe for them or may have already been unsafe for them in the first place. And so, for example, I was talking to a colleague in Honduras recently, and there was a group of about 30 unaccompanied minors that were being returned. And our team there has been trying to build the capacity of the child protection authorities to quarantine them, but there's not always enough space to meet the need for families and children that need to be quarantined for the 14 days to get the medical screening and then be returned to their communities. And so our colleagues there helps triage these kids. They were able to find a local church in the southern part of the country that was able to host them, which was a success. We were glad to hear that. They were transported to the community, but as soon as the community members learned that there were deportees brought to their community, they actually lit a fire around the church to try and prevent them from leaving. And so we have this sort of intersection of the xenophobia, the misinformation about the spread. And so the way that we've tried to mitigate that is, one, to help with the quarantining, so that to make sure that kids are getting as much access to the protection that they need in the process, and then working through our community-based partners, and again, working through local leaders is as I think Erica was saying, it's not just the message, but it's who's spreading the message. So we're working through the local mayors, through the kind of child advocacy groups that we've worked to form throughout the year, to share information about the way that COVID-19 works, and to share the fact that these kids have been quarantined, that they are okay, that they're not showing symptoms, that they're okay to let back into your homes. And so in a nutshell, these are two problems that are embedded within kind of the issues that we were already seeing with the migration trends along the corridor, but they've just been more complex as NGOs are moving remotely, and xenophobia is heightened, and the use of detention continues. And I will pause there, and I think we're going to open up for questions, I believe.
Yeah, thank you, Etan. Thank you for sharing those specific stories. We are going to open it up to Q&A. So again, if you have a question, go to the Q&A tab at the bottom of your screen and type in a question there. I have a first question to kick things off. So as the panelists are answering this question, please think of yours and type it in the Q&A box. So as Etan was just talking, and many of you have alluded to this, the idea of xenophobia is growing around a lot of these issues. But at the same time, we've experienced COVID-19 here in the United States. So in some ways, there should be an impetus for us to come together as a global community. So my question is, what do you think in the future? What's going to happen maybe a year from now? Is this going to bring us together as a global community, or create growing isolationist or growing nationalist around as people look inward? Betsy, let's start with you.
Yeah, I think that's a great question. And it's really not clear where we'll end up after this pandemic. I think the pandemic really shakes up a lot of sort of pre-existing assumptions in the global community, and probably also it hopefully heightens the increased vulnerabilities people like refugees and displaced people are facing each day, and hopefully brings us towards a more collective view of how we can even prevent displacement. I'm concerned, though, that there's threats to us coming out of this pandemic better off and actually being worse off because of a couple of things. I think one is the investments of countries' international aid and development budgets can often be controversial, and just with ongoing trends of nationalism in powerful countries, we see people start to question, should we even be putting our budgets towards that international aid and development, and not really considering the life-saving effects that that aid has. So I'm hoping that it causes us to re-examine some of those things. But then also too, I'm concerned as this pandemic is truly pandemic and affects every continent, that nations' budgets are going to be potentially much lower, and there's a lot of political pressure to focus on economic recovery internally and implement austerity measures to recover from the debt that people are incurring, and that brings us back inwards. I think also too, the impact on private philanthropy is also one to consider of, will people consider this an opportunity to be even more generous, and to be innovative on how can we further stop these kind of outbreaks, especially in the most vulnerable of communities? Or will the stock market decline and other needs domestically pull philanthropy in other directions globally? So those are just two thoughts that I've had.
Great, thank you. Erica, do you have thoughts on this too?
Yeah, maybe let me it depends on the day whether I feel quite positive about this or whether I just think, oh, this is just going to make everything that's already hard harder. So let me be, it's sunny, I've had good coffee, let me be positive today. So I think one of the opportunities that this poses is it's so hard for, especially as Betsy talked about, for people in the US where there's a lot of private philanthropy, it's so hard in a lot of these other emergencies for people to even imagine what it would be like to flee your home and to be a victim of genocide. And I think one of the opportunities that this pandemic presents is just the opportunity to bridge the gap. It's a little bit easier to imagine if it's so hard to be home right now with your kids. It's a little bit easier to imagine how much harder that would be if you were living in a refugee camp, or if you were illiterate, or if you didn't have a strong Ministry of Education or the internet or something. So I think in some ways people can identify more with the needs of others, and I think that may bring them out of themselves in new ways. So, and we've seen that, I think, at World Vision in some of the ways that our donors have been engaging differently than they have with other crises. I think the other opportunity may also be that this pandemic shows us how truly connected we all are in terms of risks. So we may get a handle on it in one country, but unless we just fully close our borders, if this is continuing to spread in other countries, there is still a risk for us. So it may be a bit more self-interested, but international aid, connecting it with what are our needs in the US here, that controlling a pandemic in another part of the world is a part of protecting ourselves. And so I think even people who are self-interested, that you may be able to bridge that gap a little bit better than we have before. So those are the two things that make me hopeful when I'm in a good place about all of this.
Those are good thoughts, very good thoughts. Etan, what do you think?
It's a great question, and it's one that I think we could have had an entire panel discussion about. And I mean, similar to what Erica was saying, even for us, I mean, for me, sitting in the comfort of my own home, I find myself experiencing highs and lows, and we have our fears for our families and getting it ourselves. But I think ultimately it depends where you look, and I think in practice right now, we're seeing it, unfortunately, the reality that it's not bringing people closer together, right? I mean, we're seeing border closures to, right? I mean, I mentioned the effective lack of access to asylum processes upon arrival to the United States. Asylum seekers are such a small percentage of the actual border crossings that happen, and then there's already so much oversight that happens, and the fact that this was used in order to kind of close them, and in addition to the already existing xenophobia, they're coming to steal our jobs or whatever the case may be. It's rather bleak. But I think that there is opportunity now when people are at home, when people are paying more attention to kind of the news, to hammer home the messages that organizations like ours have been beating for quite a while now. And these are about the realities of globalization, and kind of exactly as Erica was saying, just because we're seeing an issue in Wuhan, China, or elsewhere in the world, we have to be looking at these issues as if they are our own problems because of the way that globalization works. And we've seen, whether it's trying to deport our way out of problems before, whether it was gang violence in the United States and sending it to Central America, in the way that that has continued to impact us and impact children in particular negatively. We need to be looking at it for that lens. And again, taking the opportunity to reach people, to message it in such a way that it's not us versus them, it's us and them, to try and bridge that gap as best we can.
That's great. Thank you. Thank you for all thinking positive on a sunny day in the Seattle area, at least. So we have some questions coming in. One thing is about the global food chain, food supply. Dixie is a dietitian, and she's interested in how the disruptions in the food chain are impacting the refugee communities and food aid in particular. Betsy, do you want to start with this one?
Yeah, happy to start, and then I'm sure Erica too. World Vision's involvement in food assistance is quite vast. I think generally there's concerns about just the cost of basic goods, be that food or soap, and other commodities are increasing, and just that refugee and displaced income is often quite fixed and it's quite far down. But then also just thinking too, there's so many challenges around much of the transport systems for food is disrupted, like we were just saying, due to closed borders. Some countries have been quite shrewd and implemented rigorous testing at their border checkpoints to keep those food flows going and keep commodities in the market. But as we see, Uganda, for example, has done a spectacular job testing truck drivers, but they just continue. I think yesterday they found 24 positive cases amongst truck drivers typically driving between Kenya and Uganda or Tanzania. And how do we address that transmission route so that we can look at the larger food supply chain in East Africa to limit the impact on lower income households is one concern that we've had.
And maybe just to piggyback on that, I think, so when I think about food aid, I think about it as commodities or as cash. And so when we think about commodities, like actually, like Betsy was talking about, moving food aid from one country into another country, and then storing that food aid and distributing it to refugees, I think we've seen more disruption there. But I think there are a lot of opportunities around cash-based programming. So for instance, in the Rohingya camps, World Vision does a lot of work with World Food Program in terms of distributions, and we've done both commodities and cash, but we're shifting more towards cash programming because even though international supply chains have been interrupted, local markets tend to still be functioning within the country. And so if you can get food within the country, instead of giving someone a sack of grains, they get like a cash voucher, and then they can go into a WFP World Vision market where they can buy onions or rice or whatever it is that their team needs. And I think in some ways that's a much more dignifying way to receive aid, and there are a lot of vested interests around why we do commodities more than cash. And so I think as this crisis develops and people have the opportunity to access more cash programming, I think it will provide some really good lessons learned in the long term to ensure that we can give people the most flexible, dignifying aid that we can. So again, I'm feeling very hopeful about it today, although I think there are challenges. I think there's great opportunities.
That's great. Go ahead.
And just to add one thing is, as I suppose on the other side of it is then being able to access the food once it makes its way through the supply chain. I think that's another place where in our individual capacities, we also have some ability to do advocacy to make sure that, for example, public benefits, whether it's SNAP benefits in the United States or access in other parts of of high-income countries, that they don't discriminate based off of immigration status, that they are available to every single person, regardless of where they're from and where they're going.
That's great. Global Washington hosted an event last week on food security in particular, and the whole idea of building up local food systems could, like you said, could be a benefit, and that our global system that's based on efficiency and exports should be turned on its head right now, and that there really could be some local markets, and making sure that those local markets are maybe the last thing that are shut down in a pandemic, and that we need to keep those. So we have another question. Again, maybe I'll go back to Betsy to start. Have you seen that there are systems that were in place for the Ebola outbreak that have been used right now or activated in this pandemic?
Yeah, absolutely. And just to mention a few, medical teams has been active in Uganda, right on the Congolese border, where you see usually hundreds, sometimes thousands of Congolese coming into Uganda on a daily basis. And we were a part of this screening of those individuals. Some came by foot, some came by, that border is actually a lake in some places. So they came by boat and then were screened and provided a transit center with basic services and health screening, just to make sure, I mean, for general health purposes, and then just make sure if there were any Ebola suspected cases in those populations, that they could be identified and isolated. So for COVID-19, the system is exactly the same, just rigorous screening, be that at a border or when someone presents at a clinic and let's say is coming to deliver a child. If they have fever, we can divert them to an isolated area, because one of the most important things is keeping your health clinics running and not impacting the overall service delivery at that level. Other things is too, there's actually, in that part of the world, there's a lot of infrastructure, even on the treatment side for Ebola, and we've converted some of our Ebola treatment centers into COVID treatment centers. Again, it's a very similar setup, and infection prevention and control is one of the main things that staff are already trained on, that for preparedness in that response. So a lot of that you can move over, and there's similarities on community surveillance and contact tracing as well.
Great. Erica, do you have anything to add to that?
Yeah, I think that while especially the system in DRC is really kind of exhausted from Ebola, I think that the health systems are really strong in a lot of these in DRC, and then in the West African countries that had the Ebola outbreak a few years ago. The Ministry of Health has just thought through, what does pandemic control look like, and what systems are needed, and how is the national level connecting with the local level. And I think with COVID-19, a lot of those systems are just being slightly pivoted to work for this pandemic. And so I think they may, there are a lot of opportunities there. I also think communities are just more used to thinking about hand washing and distancing, and that's not abnormal for them and something that they're used to adjusting, and so they can protect themselves better. And then along with the sort of official health systems and the individual skills, I think there's a lot of community networks that have been set up around reducing stigma against Ebola, supporting children while their parents maybe are in isolation or something like that. And those community networks can really be mobilized again to help make sure the community can get through what's happening. So I think there's a lot of assets that are there that maybe weren't there before Ebola.
Great. And Etan, I have a different question for you, if you can answer this one. You can add on to that topic as well. But are you seeing, as you're working with the other teams at UNICEF, differences in Central America, country by country? I know there's been a different response by governments in different countries in Central America. And as Erica was mentioning, the importance of the government response, the Ministry of Health, down to the community level. But can you talk about a general difference, or is there a country that you feel like is doing really well that you want to lift up?
That's a good question. I think Yeah, we want to be careful not to group too many of the Central American countries into one. I mean, so their systems are built so differently, as everyone knows, and as you know, and their responses have varied slightly. I mean, I think the reality is the three countries that I mentioned, some of the similarities amongst Guatemala, El Salvador, Honduras, and some of the others, is that they're somewhat have acknowledged the fact that their health systems don't have the capacity to deal with an outbreak. So they have very, very strict lockdown procedures that they've put in place, where there's limitations by the amount of days that you can go outside and which hours you can be outside, and where you can and can't go. What's been somewhat interesting too is the way that, the reality is that in a lot of these communities, that the gang leaders sort of are the local leaders, and the way that they have acted as sort of a government enforcement agency of a lot of these whether it's social distancing or the lockdown or staying inside. But then the flip side of that is that goes unchecked a lot of the time, and that's where we're seeing kind of these xenophobic outbreaks, and so we're trying to work with them to message in that way.
Great, thank you. Another question also gets to, and each of you have touched on this a little bit, but the whole idea of how your staff is working in these areas. I've heard from other nonprofits that, their staff are quarantined in their house and are not providing services. I just want to hear a little bit, you all mentioned this, but one of the questions touches on this woman works with the mobile health education teams. And Erica, you mentioned going out with megaphones in the Rohingya camps. Just give us a little bit more understanding of how your organizations are working on the ground with the staff. Are they able to provide the services and get information out in particular in refugee camps or with IDPs? Betsy, you want to start?
Sure, that's a great question. I've been very encouraged. A number of weeks ago, when most countries were going into lockdown, probably early April or so, we saw systems and decision-making started around what are the essential services needed for refugees and displaced people, and then processes to issue passes or permissions or clarity on how humanitarian staff, especially those local staff and community members that serve those essential functions of sharing information, doing surveillance, those are in place, which are greatly appreciated. The difficulty is often those are at the local level, which is absolutely where they should be, but then there's still challenges around, for example, getting from the capital of a country out to a refugee camp. Refugee camps are notoriously far away from capital cities, and things like, are the gas stations open between here and there? One issue we've had is hotels aren't open, and it requires a special permission from a local mayor to open a hotel for a humanitarian to stay at a hotel. And so that delays the trip. So it's a mixed bag. There's been some good adaptations, but even as governance authorities make decisions to keep communities safe, to operate in those boundaries, it still takes a lot of creativity.
And Betsy, are you able to provide PPE for your staff, and what does that look like?
Yeah, PPE is a topic I think on everyone's programmatic impediment list, and just how do we solve this creatively? We have a program at medical teams where we accept medical equipment and supplies, and we were actually able to, in the early days, as we saw it was not a pandemic at that stage, we were able to get a number of things like N95 masks and gowns from a donor, and get those into our warehouse. And we've been able to ship those into some of our programs, and also just scale up what can we purchase locally, which we've had some success there. But for medical teams, we're so closely connected with the UN High Commission of Refugees. A lot of times they actually bring the supplies to us or have another partner that does the purchasing. So far, we're okay. The problem is with COVID-19, our consumption of personal protective equipment is extremely high because you have additional staff screening, or you have people wearing surgical masks in a consultation room where maybe they weren't doing that before. So we're trying to keep 5 or 6 months out in front of our need for PPE to make sure our staff on the front line can be safeguarded throughout however long this outbreak lasts.
Great. Thanks. Erica, do you have thoughts on this question too?
Yeah, I think specifically around thinking about PPE, I think that's just it's a big hot button issue right now. The US government has recently released guidance that no US government funding can be used to procure PPE because they don't want it to be seen that foreign aid is competing on the market for PPE that's needed in the US. And so what that means is that, we may be implementing a USAID award in Afghanistan where we are legally required for our staff to be wearing PPE when they access areas, but we've been told that we can't procure it. So how do we find other funding for PPE and compete for PPE on the market? I think that's a big issue that a lot of our organizations are dealing with, where we are receiving US government funding but can't safely implement it. I forget what the earlier question was. The PPE thing is
how your staff are working on the ground, if maybe they're in a situation where they're in lockdown, or how.
Yeah, so we definitely have in all these camps for sure a reduced footprint and an increased reliance on local volunteers, either from the refugee or from the host community, and on local staff. So the footprint is really reduced, but as Betsy said, a lot of governments have quite quickly, surprisingly for us, faster than we expected, shifted to allow for critical care and humanitarian assistance to continue to some extent.
Great. I'm going to shift to one last question for all of you that is more future thinking. One of the questions that came in is about if you think COVID-19 is going to change the basic conditions right now in refugee camps, for example, emphasizing more emphasis on clean water sanitation, or having camps so that people aren't so cramped together. And then just broader, what do you think is a possible outcome in the future post-COVID, which again, we might be living with COVID for maybe forever, but think about the future and maybe some of the positive and negative implications for refugee camps, IDPs, and migrants. Betsy, you want to start?
That's a great big question. I will try to give it a brief stab, and hopefully the other panelists can add to. My hope is this crisis, like Erica highlighted, really highlights the disparities of investment, and then the benefits as well of there are various ways to manage refugee flows. And some of those are to put people in a very tightly packed camp, and some of them are in settlements where people will get 5 or 10 acres of land. And just, I think it will cause us to think more thoughtfully about how can we better plan refugee support in ways that systematically reduce their vulnerabilities to outbreaks and other things, even just like the quality of their shelter and how well it could survive, for example, an earthquake. So I think it will help us see those disparities of really great ways to accommodate refugees, but it will also highlight some of the ways that really the management of those responses and what's happened has increased those vulnerabilities. So I think there's a lot of opportunities for us to think carefully, and I hope causes people to be more generous as they think about what can be done for refugees, but also to plant one thought out there as we're talking about displacement today is, I hope that this can also help us think about how can we stop displacement altogether and look at those drivers for displacement, be that unaffordable food, inaccessible healthcare. And I really hope the pandemic doesn't actually cause more of those, and we're sitting 12 or 24 months down the road and we don't have 70 million people displaced globally, but we have 100 million people displaced globally. So I think really looking at how can we better invest in even some of those chronic drivers of conflict and unrest that force displacement.
Thanks, Betsy. I think that was both a little bit optimistic and a little bit pessimistic, or maybe a warning that we need to act and we need to be thoughtful about the future in this. Erica, do you want to go next?
Sure, yeah, I think so. There are already some really good minimum standards that should be achieved in refugee camps that are really hard to maintain. And I think one thing that this will do is give more of a pandemic lens to those standards. So if the minimum standard is that 20 people access this kind of latrine, what does that look like in a pandemic when it's if 20 people are accessing the latrine, that's an inherently vulnerable place. But I think, you know, for instance, the cholera outbreaks in Haiti, I think we had hopes that that would change the humanitarian system and have us learn. I don't think we learned as much from that as we should have. I think these refugee camps before COVID were really vulnerable to some of these communicable diseases. And so I think there will be opportunities for us to add a new lens of what we need to be looking at and what we should be providing, but the gap between the guidance and what we know is safest for these refugees and then what's actually provided from them, I think that's been a perennial problem that's been really hard to achieve and solve for.
Thanks, Erica. Etan, what do you think? Is there something that we could learn from this pandemic that could improve the issues of migration flows?
Yeah, I mean, without wanting to repeat with what Erica and Betsy already mentioned, I think they've covered us well on the refugee camp status. I mean, for example, what Erica was saying about a lot of times we have these policies and practices in place, but there's a lack of implementation of them. And so trying to bridge that gap is, I think, important. But then I guess to talk about kind of policies towards refugees, asylum seekers, and migrants, I'm hopeful that it'll get us to rethink things like immigration detention from a different lens. And this kind of gets at that, is this an opportunity to look at it in a new lens, even if we're talking about it in terms of protecting the immigration officers from contracting things like COVID because they're in the facilities. At the end of the day, if the end game of reducing use or ending use of child immigration detention as a result, and that's an okay lens for us to look at. I mean, the result is, I think, what's important. So I think at the end, it's obviously a serious issue, but it's an opportunity to look at things with that different angle and to think more creatively about how we can get to the world that we ultimately want to see.
Great. Thank you all for being on this panel today. It was really informative. It's such an important topic, and I learned a lot. So thank you all for presenting. We're at the end of our program today. Thank you all for joining us. And again, Global Washington will be continuing to provide information. Please go to globalwashington.org to find out future events and future topics. You should have all received also the issue brief we have on this that you can share with others. If you're a Global Washington member, you can have this video recording as well. So if there are colleagues of yours that couldn't join, let us know and we can pass on the video. Thank you all. Thank you again, panelists, for sharing what you know on this. And everyone have a good weekend. Thank you all.
Thanks, Kristen.
Bye. Thank you.
Thanks.